Yes, now I request Dr. Ragini, who is from Mumbai. He's also having a lot of experience in doing SICS, and not only SICS, PAREKH as well, but he also popularized this SICS in difficult situations. Certain situations sometimes it's difficult to perform the PAREKH. So the SICS is another option, good option. If you make the vision 6 and control this estimate is very equally good. And the subluxated cataract is again a very challenging situation. And now how can proceed? So I request you.
Thank you, sir. Respected Singh sir, my teacher Padma Shri Dr. Lani sir, my close friend and promoter and teacher of SICS Ruchi, Dr. Shama, all respected seniors and friends. So SICS and subluxated cataract. There are situations which are different than in which cases you don't want to or you are scared to do phacoemulsification, and that is when SICS comes to the rescue. The risk factors will be trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, sulfite oxidase deficiency. These are some conditions where you find that the cataract could be subluxated. And if you have such a patient, then it is better to look for it, do a slit lamp examination, and be aware that subluxations can be possible. Progressive and generalized weakness can be in trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, and sulfite oxidase deficiency. These are conditions where one must be aware of the pre-existing subluxation. So how will you manage the patient? Investigation, pre-operative precautions, intraoperative care, and the post-operative monitoring. So we divide the management into these 4 parts. Now we are talking about investigations. So a slit lamp examination, if possible a UBM, if you have access to it, it is expensive, so you have to consider the patient's finances also. In cases of trauma, there may be associated injuries or something abnormal in the posterior segment. So B-scan ultrasonography, even for medico-legal purposes, and retinal examination, these are very, very important. So pre-operative precautions we will be going to. So you have to counsel the patient, which is very, very important, that the need, the presence of a complicated and the need of a prolonged surgery, the potential need for a vitrectomy, the risk of retinal detachment, cystoid macular edema, and vitreous loss, the need for a second surgery because primary intraocular lens may not be possible. Management will include investigations, pre-operative precautions, intraoperative management, and post-operative monitoring. So whenever you are trying to do it, it should be, the incision should be placed away from the area of zonular weakness if possible. It may not be always possible. Incision in the gradient opposite to the zone of maximum zonular weakness, but at the same time we should not jeopardize his surgical ability by operating in a meridian that we are uncomfortable. Sclerocorneal incision allows the ease of incision to be converted into a SICS. A generous amount of highly retentive viscoelastic is important because you want to maintain and you want to prevent the vitreous from entering into the anterior chamber. Capsulorhexis, it is important that in the capsulorhexis, you need to do a proper capsulorhexis. Here the capsule is not firm and you may need to use a Utratas forceps. The use of trypan blue is very, very important because it helps you with a better visualization of a capsule so that the rhexis is performed properly, and it should be centered on the crystalline lens and not center of the dilated pupil, because the lens is first decentered. So if you center it on the lens and use CTR rings to then bring the capsular bag in place, then it should be centered on the lens. So that is very, very important. So as you can see, this is a subluxated cataract. SICS, where we are doing a dye-assisted rhexis. This is a capsulotome which we are using, and it is centered on the decentered lens. So as you can see, the capsulorhexis appears to be decentered, but it is centered on the decentered lens, because now after the rhexis we are going to use a CTR ring to bring the lens central. So this point is very, very important. Hydrodissection, you have to be very, very careful while doing these procedures, because the amount of fluid can cause more subluxation. So one has to be very, very careful in doing these procedures, and it has to be customized to each case. Now, after hydrodissection and hydro procedure, now once you have finished the surgery, there are two schools of thought that orienting the IOL in a plane parallel to the zonular dialysis. So you have to see where the bag will be stretched and where the IOL is placed in order to inflate the bag and make the lens central. That is very, very important. So orienting the IOL in a plane parallel to the zonular dialysis in order to take advantage of the remaining intact zonules. It will provide optimum support but may cause ovaling of the capsular bag. So that you have to be very, very important. And placing one haptic in the area of zonular dialysis will ensure stretching and decrease ovaling. So that is also very, very important. CTR rings have changed the way we look at subluxated cataracts, and they have made our life much, much easier. They are a prerequisite to the management of subluxated cataracts today. So they have demonstrated that they stabilize the bag. There are various sizes available. Depending on the white to white, you have to use a particular size ring, because in bigger eyes or myopic eyes, a big ring will be required. So these are the various types of rings and the sizes which are available. Like we order intraocular lenses, various sizes are available. So they can be inserted using a forceps or a specially designed injector or a fishtail technique. And CTR is fixed to the sclera using either an ab externo or an ab interno approach with a suture, right? So what is a fishtail technique? It can be used to insert the CTR where both ends are held with the forceps in a cross manner to create a central closed loop which is placed adjacent to the area of dehiscence in the capsular bag first. So that is important, and then it is released. So this is the CTR ring. As you can see, you are holding the ring with both hands and then gently putting it in such a way that it is being rotated gently into the bag. One must remember that it is a C-shaped or a circular ring. Now this eyelet, you hook the Sinskey's hook in the eyelet, and now you put it in like you put in a loop. So that is very, very important. So putting in the ring is also an important technique to learn. We have found patients with multiple CTR rings in the vitreous. So when do you insert the ring? Either you can do it before the nucleus delivery, where you think that you need to stabilize the bag before the nucleus delivery, or it can be done after the nucleus delivery before the cortex aspiration. Each case warrants different type of insertions. So that is very, very important. It should be stabilized. So putting it before stabilizes the bag and does not cause more subluxation during nucleus delivery. So I think putting it before helps me more, and it should be inserted with a simple forceps method. So contraindications of a CTR are where you do not have a rhexis, when there is a PC tear, when there is an extensive zonular weakness, and it is not used in patients with scleral disorders because it can be excluded through the sclera. So these are very important, and like I said, we found patients with multiple CTR rings in the vitreous when they came for IOL explantation. So lots of things have been tried, and then, so as you can see, this is a patient where we are doing this is a subluxated cataract where the rhexis is done, and you can see the traumatic rosette in this patient which caused the subluxation. So the rhexis is in the center of the lens. This case is used to just demonstrate certain points, and the small multiple points of hydro, as you can see. because this is not an SICS. This case is shown to demonstrate certain steps where the nucleus is separated gently and brought out of the bag, so there is no tension on the bag, because if you do anything inside the bag, so you can see even after slightly that the nucleus is removed, small hydro is done to bring the nucleus out of the bag. So that is very, very important, because if you put too much of fluid inside the bag, it will cause more subluxation, and it will cause more harm than what you want. So one has to be very, very careful. So investigations, preoperative precautions, intraoperative and postoperative monitoring. So postoperative also is extremely, extremely important, because these are the cases that cannot be left like that only. You have to check for centration of the IOL, any remnants of vitreous, because those have to be removed by vitrectomy by using tricot, and you have to see for the check of the pupil, you have to see the shape of the pupil, because the shape of the pupil will tell you whether there is any vitreous in the anterior chamber. Post-operative rise of IOP because of so much of manipulation, inflammation, and the presence of vitreous in the trabecular meshwork. Pseudophacodonesis can also cause cystoid macular edema like phacodonesis, so one must be aware and treat it beforehand, and a retina examination, because any pre-existing holes or tears can cause retinal detachment. So basically, the take-home message is that subluxated cataracts can be given satisfactory post-op results with proper pre-operative planning. Use of CTRs when indicated, I think it is a big boon. Optimum bottle height, because you do not want too much of fluid to cause even more of the capsule to be subluxated, and it is important to learn a proper vitrectomy to manage a small anterior vitrectomy is a must to manage these cases and to prevent any problems. So, yes, sir.
Thank you, Ragini.